الاستاذ الدكتور عبد الرحمن عبد الحي مختار استاذ امراض البطن العامه في طب جامعه المنصوره. He will present management of diabetes mellitus. تفضل.
السلام عليكم. Actually, my talk today is about in-hospital management of diabetes. I think this lecture will be an introduction to the topic because the time is limited, so I will give introduction. Actually, this is a series of almost 3 lectures, not 1 lecture. But why we select the in-hospital management of diabetes? I think because all of you may share me that there is a huge implementation gap between the guidelines and the recommendation and what is actually on the land in our hospitals with the different parts. There are a lot of regulatory guidelines. It can be cost effective. And by in-hospital management of diabetes, it doesn't mean the diabetic patient who is admitted for diabetes control. I mean the diabetic patient, he is in any ward, in any ward, in the nephrology department, in the gynecology department, in the ortho department, how we will deal with his diabetes. Because usually this is a missed part. Improved glycemic control is associated with improved outcomes. You may look to this slide. It shows the critical care admission in medical and surgical patients in hospital. Around 64% of admission are euglycemic. The mortality is almost 1.7%. If you look to the second sector, which is the non-diabetic patients, around 26% of hospital admission, the mortality is doubled. It becomes 3%. But what is astonishing is the last sector, which represents about 12% of hospital admission, which is presenting by hyperglycemia for the first time with the acute cause for admission. The mortality is tenfold, 16%. So again, the non-diabetic, the mortality is almost 1.7%, doubled in the non-diabetic, but tenfold increase in the patient who is presented by diabetes for the first time during hospital admission. Hospital hyperglycemia, of course, can influence the mortality and the prognosis in several factors, as you all know: deranged metabolism, impaired perfusion, the poor thrombotic milieu that diabetes produced, impaired white blood cell function and immunity, pro-inflammatory state, impaired wound healing, and impaired left ventricular function. All of this will influence the critical care prognosis, the critically ill prognosis. Again, let us go to the research. Actually, in the field of diabetes, all of you know these studies. There are 2 landmark studies for the outpatient diabetics: DCCT trial and UKPD study. These studies are well known for those, the colleagues in the field, and I think well known also for my colleague in nephrology, because after these studies, we know that strict control of diabetes will influence the microangiopathy. Equivalent to these studies, for in-hospital management of diabetes, there was 2 well-known studies: the AGAIN study, 1997, and Vandenberg study, IV insulin in surgical ICU. The Vandenberg study, we used IV insulin in surgical ICU for strict control of diabetic patients. When they studied the effect of strict control, they published these results in 2001. That mortality has been reduced by 34%, sepsis reduced by around 45%, dialysis reduced by 41%, blood transfusion by 50%, polyneuropathy by 44%. It's very good figures and very encouraging. Again, complications was correlated with the target blood glucose. You see the filled bar, the black one, the black one represents those controlled under 110 milligram per deciliter. The mortality was the least, polyneuropathy the least, bacteremia the least, inflammation the least. All complications has been reduced with this strict control. Again, Although the banded study was not designed to determine the threshold above which mortality increased, it was clear that above 110 to 150 glucose, the mortality has been markedly increased. Again, persistent post-stroke hyperglycemia was independently associated with infarct expansion and worse clinical outcome. The results of the routine studies have led to a worldwide increase in the implementation of strict glycemic control, especially in the intensive care units. The mortality reduction in these landmark trials was attributed to the strict lowering of mean glucose, which by strict lowering we mean from 80 to 110 milligram per deciliter during admission in the intervention group. These studies pushed the American Diabetes Association and the American College of Endocrinology in 2004. Don't forget we are in 2013. In 2004, they adopt these targets for ICU patient, blood glucose to be 110 milligram for American Association of Clinical Endocrinology and ACG. For ADA, they recommended 100 milligram. For non-ICU, pre-prandial target was 110 for American College of Endocrinology and 90 to 130 for ADA. For non-ICU, maximum should not exceed 180. They adopt these figures despite a lot of limitations to the Bamberg studies. Of these limitations, it was not blinded study. Most cases were recruited after cardiac surgery. So it is not completely right to take conclusion from a study on certain type of patients and popularize it to all patients. Patients received IV glucose on arrival to ICU of 200 to 300 grams per day. Parenteral nutrition, enteral feeding, or combined feedings were provided to all patients within 24 hours of ICU admission. The mortality of patients in the control group was twice the national average of Australia, for example. Intrinsic limitation of single center studies make them unsuitable for level 1 evidence. So whatever the center, be cautious to take from single center study or one sector of patients, like surgical patients, and to popularize for all. Despite these limitations, the diet glucose control express seemed unstoppable. It becomes a new era in medicine, and most of the ICU rushed to intensive insulin control until 2009. 2009, there was an emergency break. What happened? The NICE sugar trial in 2009. NICE sugar trial, this is the second largest randomized study sample in the history of critical care medicine. Around 6,000 patients included, 1 million glucose and insulin dose measurement included, multinational studies in a trial to explore the situation and to avoid the limitations of the previous studies. In this study, the patients within 24 hours after ICU admission, patients were randomly assigned to undergo either intensive glucose control, adopting the same criteria used by Vandenberg study, aiming to target blood glucose between 81 to 108 milligram per deciliter, versus the other limb conventional glucose control with a target of 180 milligram or less per deciliter. The primary endpoint was death from any cause within 90 days after randomization. So around half of the patients in the intensive glucose limb and the other half in the conventional glucose control. This, the red one, conventional glucose control, the blood glucose, the mean blood glucose was about 140 milligram per deciliter. For the intensive control, the mean was around 108 or 110. It was very surprising that this study was not completed. The difference was clear for the study, and they found that it is unethical to continue. Investigators found that compared with conventional therapy, intensive insulin treatment was associated with an increased mortality 90 days after randomization. This detrimental intensive insulin therapy mortality effect in the NICE sugar trial occurred in all subgroups. Whether medical, whether surgical, it was clear difference. Severe hypoglycemia occurred in approximately 7% of intensively treated patients compared with 0.5% of conventionally treated patients. So the study was terminated. The American Association of Clinical Endocrinology and the American Diabetes Association changed their recommendation again. The new recommendation was until more information is available, it seems reasonable for clinicians to treat critical care patients with the less intensive yet good glucose control strategies used in the conventional arm of the NICE sugar. Insulin infusion began if blood glucose was over 180 milligram per deciliter and discontinued if blood glucose dropped below 144. So these are the latest recommendations. Blood glucose less than 110 milligram is not recommended. The recommended is the green one from 140 to 180. Acceptable 110 to 140 in certain situations. And usually in cardiac surgery they need more strict control for the healing of coronaries. So before they were targeting less than 110, but now it is acceptable 110 to 140. And not recommended more than 180. So the average, for generally speaking, it is 140 to 180. This is the accepted target until any new studies. Not only this, but another study came in 2010, Hermanidis et al. It was a step beyond the glucose level. Hermanidis and Associates in 2010 published the result of another large study in Amsterdam, included around 6,000 patients also. They were studying another very important point, the association of glucose variability and mean glucose values with ICU and in-hospital mortality. So it is not only the level, it is the variability of blood glucose. Variability was measured by mean MAG, which means mean absolute glucose change per hour, and standard deviation. And let us look to this slide. It's a very nice slide. Suppose two fictitious patients. We have here two patients. Patient one, the blood glucose was very low and stable, then all of a sudden get a rise and keep very high. The average is 135 milligram per deciliter, but the standard deviation is very low. The mean variation in glucose 5 milligram per hour. The mean glucose variability is 5 milligram per hour. While the other patient is going up and down, the average is the same, 135 milligram per deciliter. But the mean glucose variability around 66 milligram per hour. Definitely the mortality here was found to be higher than the first one. In this retrospective cohort study, it has been shown that glucose variability is highly associated with ICU death in both high and low ranges of mean glucose. In combination with a high mean glucose, glucose variability seems most detrimental. This is very important because it will give you the background of the philosophy will be followed later on how to manage diabetes, because this variability is one of the hallmarks of the insulin sliding scale. I think we are using the still in larger scale. Sliding scale is an example of this up and down glucose, because the sliding scale is a reactive insulin. Now the trend is toward anticipating insulin dosage rather than reactive insulin dosage. In insulin sliding scale, you are waiting until the glucose comes out to start to react and get insulin to come down. Then again comes out and start to react. This is very determined. So this is one of the very important concepts will influence the management later on. For those with persistently high mean glucose values during admission, low glucose variability seems protective. Possibly the adaptive cell mechanisms that are initiated in case of constant hyperglycemia are ineffective when the hyperglycemia is not constant but varying, explaining the toxicity. هم حاولوا يفهموا ليه الجلوكوز فاريبيليتي بتبقى مور ديترمنتال. في احد الاكسبلينيشن انه زي اي حاجه في الجسم بيبقى فيه acclimatization mechanisms to combat against this effect of high blood glucose. But if you interrupt this glucose, you are disturbing these mechanisms. فلا منك عالجت الهاي بلاد جلوكوز ولا منك سبت الجسم يحمي نفسه. وبالتالي بناء على التو ستاديز اللي اتقالوا في الاول خلينا نتفق what will be our target. هل our target to keep the patient alive؟ ولا no DKA or hyperosmolar coma؟ ولا occasional hypo and hyperglycemia style control؟ ولا no hypo or hyperglycemia which will prevent the fluid and electrolyte abnormalities? It will improve white blood cell function, it will improve gastric emptying, decrease surgical complication, earlier hospital discharge, decrease post-MI mortality, decrease post-CABG morbidity and mortality. So almost or normal glucose control. If normal glucose control will come with more hypoglycemic attacks, still it is not recommended. We cannot recommend up till now. Okay, how we will reach this target? Actually managing diabetes in the hospital presents different challenges than managing diabetes in the outpatient area. It is a big problem. Why this like this? Because as I tell you, I'm talking about patients where diabetes is a secondary diagnosis. He is admitted in the nephrology department, in the ENT department, ophthalmology department, so the ophthalmology doctor, he needs to remove his cataract and leave diabetes 1-2 days hyperglycemia. It is not his headache. This idea should be changed. Who cares? Just get patient home. He is minded by the primary diagnosis and forget diabetes. Sliding scales are fine. This is the common sense. Avoid that scary hypoglycemia. Leave the patient to die from his diabetes rather from my insulin. This is not accepted. The inpatient diabetes goal should be normal glucose for everyone. A high glucose means failure. Sliding scales are banned. Some hypoglycemia is accepted. One of the other problems in hospital there is unstable lifestyle regime. In the ordinary life, the patient life is almost stable. We know how much he is taking meals, how much he is doing exercise, he is doing effort, so you can give him a fixed dose of anti-diabetic measure. But in the hospital, the basal metabolic rate may change, his intake may change, his sleep may change, all his life is directed. The hospital is also associated with acute illness, stress-related hyperglycemia, use of medications that improve, that impact glycemic control. A lot of medication can interfere, commonly associated with steroid, catecholamines, tacrolimus, cyclosporine, gatotoxacin, and total parental. Others less influencing but common also contraceptive pills, thiazides, atypical antipsychotics, calcium channel blockers, and protease inhibitors. So managing diabetes and hyperglycemia in this labile environment requires a flexible management strategy. Okay, for oral anti-diabetes agents in the hospital, it can be continued in certain cases. In stable patient with normal nutritional intake, normal blood glucose level, and stable renal and cardiac function. However, there are several potential disadvantages for using these medications in hospital patients. يبقى الأصل to shift to insulin. This disadvantage you all know. Most of oral agents slow acting, difficult to titrate, hypoglycemia if caloric intake is reduced, especially with sulfonylureas. Metformin can cause lactic acidosis, especially with cardiac and chest patients, renal patients. Slow onset of action, GI complications. Thiazolene diones, you all know that cause fluid and salt retention and heart failure, congestive heart failure. Alpha glucosidase also can cause abdominal bloating. The new groups, newer agents, still data did not support use in hospital. So we are looking for another agent, which is insulin. So the principle, we will shift to insulin. Okay, how we will shift to insulin? Let us see the story of Tom and Harry. Tom is 65 years old, twins, Tom and Harry. Diabetes on NPH 20 units and oral hypoglycemics with poor control, neither sees medical doctor regularly, smokers. At a gentleman's club, when both develop chest pain, after 6 hours, Tom goes to hospital A, Harry when hospital A is full, so he went to hospital B. Tom at hospital A admitted to CCU, myocardial infarction confirmed, glucose 230 mg per deciliter, no infusion started for 18 hours, infusion control poor, glycemic excursions when Tom eats, recurrent hypoglycemia, treated inconsistently, especially with trips to radiology. They omit the meal for the radiology and given the insulin, not given insulin, finally controlled on infusion day 4. Transition toward Tom on sliding scale, recurrent hyperglycemia to 300 mg, brief return to urine, confusion with various insulin regimens as Tom goes from eating to NPO several times, no mention of hyperglycemia in discharge summary, Tom discharged on same medications as admitted, length of stay 6 days, ejection fraction 35% at 1 month. Follow up with cardiology only, glycemic control remains poor, recurrent cardiovascular events, recurrent hospitalization. Let us see what happened with that. Harry at hospital B admitted CCU, myocardial infarction, confirmed glucose 230 mg per deciliter. Infusion started by protocol when glucose was more than 140 to 180 mg per deciliter. Glycemic excursions with meals covered with subcutaneous rapid-acting analog insulins as per protocol. Minor hypoglycemia is covered routinely. Any protocol, there is recommendation for hypoglycemia. Transition toward on basal bolus regimen. Total daily dose of 80 units per day. A1C obtained was 10. When Harry goes NPO for test, nurses continue basal insulin and hold nutritional insulin as per protocol. Education on smoking, cessation, and diabetes mellitus, information about DM, glucose control included in the discharge summary. Hospitalists arranged for family medicine discharge regimen of Larkin, 35 and 8 units rapid active analog with meals. Length of stay was 5 days. Ejection fraction at 1 month was 45%. Harry 3 years later, kids smoking, A1C 6.2, not re-hospitalized. What does the story tell? Of course, it is not the insulin, it is how we are using the tool. Despite widespread use of insulin, implementation gap is there. 1/3 is still with mean glucose more than 200. 60 to 70% of insulin regimens is still sliding scale only, even if horrible control. More than 10% with hypoglycemic episodes, uneven training among staff, poor coordination of tray delivery, monitoring, and insulin. This is a big problem, even in the cells they are discussing this. Tray delivery, monitoring, and insulin. الحكيمه بتاخد قرايه الجلوكوز الساعه 6 السهرانه بتاخدها، وبعدين الفطار يجي الساعه 8 والعيان ياخد الانسولين على قرايه الساعه 6 وبعدين ممكن ما ياكلش الا الساعه 9. ازاي نعمل هارمونايزيشن بين الثلاثه دول؟ This is a big problem and there are a lot of solutions. Patients often confuse or so it is not only the tool but how we are using the tool. How do we close the gap? Institutional support and multidisciplinary teams, standardized order sets, infusion and subcutaneous which promote basal bolus regimens, algorithms, protocols, policies addressing dosing, nutritional intake, special situations, safety issues, transitions in care and discharge, comprehensive educational programs. واعتقد ان اكتفي بهذا القدر لانه how to implement this المفروض في another second لو يعني سمحتوا لي حضراتكم في فرصه ثانيه، بس دي كانت الفلسفي behind البروتوكولز اللي هي موجوده في كل الدنيا. Thanks a lot.
شفت